Welcome to Between Two Ovaries, your go-to for all things women's health.
A lot of people just say like, oh, my vagina.
Yeah.
And
Yes.
that's
all
not,
of the above.
That's not your vagina.
No.
Well, it is.
We're here to cut through the confusion, bust some myths, and give you the facts straight from the experts.
You cannot still believe the amount of people that come to a gynecology clinic saying that they don't look right down there and they need something doing about it.
We're keeping it real, bringing you honest conversations about topics that matter to you.
Everything goes back to the menstrual cycle. Yes, it's a low-risk procedure, but it's not a no-risk procedure.
From periods to menopause and everything in between, we've got you covered.
So whether you're here to learn, laugh, or just listen, you are in the right place.
As soon as I said it.
Hi everyone, so today's episode is called Adenomyosis, I Don't Know Myosis.
I like it. So adenomyosis has become a lot more apparent in the press quite recently. I think that's because it's had some big names behind it. So we know Naga Munchetty has spoken about having adenomyosis, being diagnosed in the last few years. And there's also some other kind of celebrities that have come out, and we've got these adeno warriors that have done loads of work for adenomyosis as well. And we still find that a lot of people genuinely just don't know what adenomyosis is. And that's with reason, because I think there's really not much research going into it, which means that what we're saying to people is we think that this is what's happening, we think this is the best way to treat it, but there isn't kind of a set way of what to do. So we thought it was important to kind of tell people what there is out there about adenomyosis so we can find out what we don't know about it, and try and educate people.
Yeah. Okay, so adenomyosis. We don't know meiosis. What is it?
So adenomyosis, interestingly, was first actually described medically over 100 years ago.
Oh, she's got a long history.
A long history, but then not much progress has been made in trying to understand what it means and how to treat it best and how to, improve how we treat it. So what it actually is, definition-wise, if we think back to our anatomy of the uterus, so you've got your womb. Inside the womb is a lining called the endometrium. Then just outside that is a big chunky muscle layer called the myometrium, and then just a layer on the outside that's kind of like the uterus's skin called the serosa. So in adenomyosis, the endometrium and the myometrium should have a really nice clear border between them, but for some reason, and we'll talk a bit about why that might be, the endometrium grows into the myometrium. So you get abnormal endometrial growths into the muscle layer of the womb. And that is exactly what adenomyosis is. So the lining of the womb in the muscle of the womb. Yeah. In a nutshell.
Yeah. And
where it shouldn't be. It shouldn't be there at all.
Just cross that border.
Yeah.
How common/uncommon is it?
So it's sort of, it's previously probably been underestimated. So at the moment, most of the research will say about 10 to 20% of women of reproductive age, so from the age you start your periods until menopause, will have evidence of adenomyosis. But it used to be, so the only way to reliably, the best way to diagnose it is actually you have your womb removed, you have a hysterectomy, and then a pathologist looks at your womb under the microscope and says, look, there's endometrium in the wrong place. This person's got adenomyosis.
This person had adenomyosis.
Had adenomyosis. Yeah. So if you think about the kind of typical person who might be having a hysterectomy, they tend to be women who are in their 40s, 50s. They tend to be women whose family are complete, so they probably had children in the past, and they're usually having the hysterectomy for heavy bleeding.
So it was... Sorry.
They previously thought that it was only really affecting women in their 40s and 50s. But then over the last 2 decades, we've got better at doing images like ultrasound scans and MRI scans, which can show what we think is adenomyosis. And then we know that actually younger women can get it too.
Okay.
Yeah. So it's probably somewhere between 10 and 20%, but it's been really difficult to know exactly how many people have it because it's so hard to get a definitive diagnosis.
I think it used to just not be a thing.
So
we knew that there was this condition called adenomyosis, and in pathology reports, so when the womb is sent to the lab and a specialist looks at the muscle and says there's endometrium in the muscle, then that's adenomyosis. We would find out then, and you
Yeah.
wouldn't ever really discuss it before. On some scans, sometimes someone would maybe mention that there could be adenomyosis present, but genuinely, because it was thought to be a diagnosis that was a histological diagnosis when there was a specimen in the lab, and we couldn't do anything about it because the only thing you can do is kind of remove the womb and see it when the
Is obviously a
specimen's in
big
the
procedure.
lab. That it kind of just wasn't mentioned.
No.
It's only been the last, I feel like, decade or something,
Yeah.
that it's become a lot more apparent that this is a condition and people have symptoms from it. What can we do about it? What causes it? What do we need to do in the future? And because of the popularity recently with people kind of getting the name out there, I think this has really aided people, the understanding of it.
Yeah,
Okay.
definitely. So you're going to ask a question before. What
You
was
covered it.
Great.
Well done.
That
Yeah, I think
is
it goes,
good.
as you said, like it kind of goes hand in hand with like now that we can almost reliably, it's not 100%, but if you have an ultrasound scan or an MRI scan and you see signs of adenomyosis and that person has the symptoms that we think are associated with it, like pain and heavy periods, then now you can diagnose it before having a hysterectomy. Whereas before we didn't have that, so we didn't, we weren't able to say, oh, it could be this, because we couldn't see it until you'd had a hysterectomy. And then you've had a hysterectomy, and if it's just adenomyosis that's causing your pain, then that technically should cure it because you've removed the thing that's causing the problem. So it's really changed, hasn't it? Like how we like talk about it, and
Well, you wouldn't now not mention if
No.
signs and symptoms of
Yeah.
seen, whereas before it just kind of wasn't anything that you would even look at. You wouldn't look to see these different points on an ultrasound scan. You wouldn't, because it wasn't a thing.
yeah, the sonographer wouldn't know what they were, like, how to identify it. But anyway, it's changed.
So we've moved on.
Yeah,
We've
we've moved on.
forward.
Definitely
That's
move
good.
forward. I don't know if I don't imagine that things have gotten a lot better with moving forward.
Not moving
Yeah.
forward
with
enough, but
yeah.
moving forward.
But with
A
regards to a diagnosis, I think more and more people are getting a diagnosis. And that's why it's important for us to tell people what it is so that they can understand what it is and what symptoms it might be causing.
Yeah.
So why does it happen?
So it's a really good question, and there isn't a definite, we know this is the cause of adenomyosis.
Okay.
Similar with endometriosis, like there's some theories, as we've discussed in our previous episode about endometriosis. It's a very similar picture with adenomyosis. So we don't know 100%, but there are sort of like theories. One theory is that, as I mentioned before, that border between the endometrium and the myometrium should be really nice and clear, and they should be two distinct kind of regions. But anything that might cause injury to that area might be triggering adenomyosis.
Okay.
So for example, and that this can be like anything basically, so even just having a period technically can cause sort of damage at that area. Having a baby can cause a bit of damage at that area, or having surgeries like what we kind of call a D&C procedure. If you've had like a termination of pregnancy and you have a surgical termination of pregnancy,
Okay.
it's like a lot of people call it a D&C, which stands for dilatation and curettage, or a
Which we
suction
don't. I was
evacuation
going to say
of
we
the
don't really do
uterus.
anymore. So it's
No.
more like an evac. So an evacuation.
suction of anything outside, anything in your womb to
Okay,
remove
yeah.
it.
To
kind
remove
of a
everything,
suction.
yeah.
Anything that might cause a bit of damage at that border is thought to potentially cause adenomyosis, not proven. So you can have all of the above, lots of periods, lots of children, lots of terminations, and not have adenomyosis.
Can you also have not had any sort of injury and still get it?
Yeah,
Okay.
definitely.
So that's why it doesn't fit. And we've said this before with endometriosis. There isn't a theory, in inverted commas, that fits the symptoms, fits the signs, and fits in with everybody. So you don't follow a pattern of, if you do, like if you cross a road and there's a car coming, you are going to get run over. If you, this isn't how it
It's a lot more
follows
complicated.
Yeah.
when you've got adenomyosis, because you might have had children, not had children, unfortunately had lots of miscarriage, not had lots of miscarriages, terminations, no terminations. You can have had all of these things and still have adenomyosis or not have adenomyosis.
Yeah.
So there's not a good
No.
theory
So we
that
don't know
fits.
We
No.
don't know exactly. And also you can get some young women, even, in their early, like late teens, early 20s, who have a scan for some reason and have signs of adenomyosis on there. And that doesn't fit in with what, we thought was a typical person with adenomyosis.
Although we definitely see it more common in people when they get older.
Yeah.
So when people are kind of getting over 35, over 40, over 45, I would say that you can see changes on a lot of people's scans that you do.
Yeah.
So kind of more of most than not at all.
Yeah.
Whereas when people are younger, you don't see it often.
Yeah.
Okay, so it could be anyone with a womb, but it's more likely to be someone a little bit older.
Yeah.
We see it more commonly in older women,
Okay.
but it is also there. Like, there's a lot of studies in like fertility clinics where people are having ultrasound scans, and they'll pick up on signs of what looks like adenomyosis. So then we're aware that it doesn't just affect women in their 40s. It also seems to affect some women in their like their late teens, early 20s, 30s as well. Yeah.
And what are the symptoms? What are the effects of it?
Go on.
So
I like that pass.
So you can have various different. So you could have a scan for something completely irrelevant to that, and you could find out to have adenomyosis and just say, well, you have normal periods, don't have any problems.
So it could be like no symptoms.
Yeah,
symptoms.
that's a really, like, just like with endometriosis, you know, we've got this spectrum of like someone might have a surgery for another reason, like having a sterilisation, and then when their camera's in the tummy, you can see that they've got loads of endometriosis, but they don't have any symptoms, they have no problems.
They've had 4 children,
Yeah.
they've had no
Lived their
problem
life,
getting
yeah.
pregnant.
You can have that with adenomyosis as well. Someone might have an MRI scan for another reason, no problems with the periods, no pain,
And
but
just
there is
spot it.
adenomyosis there. Yeah.
So, or you could be left with debilitatingly heavy and painful periods.
Yeah.
So that's the main symptoms that you would get with adenomyosis. So painful, heavy periods caused by kind of this endometrium lining of your womb in the muscle of your womb.
Yeah.
Is that because the tissue that's in the muscle is still trying to have that period, but it's in the muscle?
Yeah.
Oh, God.
So it's still responding to the hormones that are causing the lining of the womb to shed from the right place, but it's trapped in the muscle layer. So
you're like bleeding in your muscle.
yeah, and then you can get
Oh.
like there's inflammation, so there's pain from the inflammation, then there's scarring, then there's the fact that the muscle layer, because it's scarred and inflamed, doesn't function
It's
normally.
kind of inefficient.
Yeah.
So you want it to contract down so that your periods aren't heavy. So and it's not doing that
Yeah.
because it's inefficient, because
Yeah.
it's got these different little cysts and different pieces of endometrium
Bits.
within the lining.
Yeah.
And you can also get, because you've got heavy painful periods, you can get pains radiating down your legs, and heaviness.
Yeah.
So
Tiredness,
Yeah.
bloating, all of those things. Because if you imagine you've got this big inflamed ball in your pelvis.
like globular.
Yeah,
womb,
because your
like-
womb can be bigger because of all this inflammation, and that can irritate the nerves that are in your pelvis. So you might get referred pain in other places. You might get back pain. Yeah, there's lots of different symptoms you can get. Yeah.
And how's it diagnosed? Is there like a main procedure that's
So
used?
gold
or-
standard, as we said, is to have a womb under a
Take it out,
microscope,
look,
have
yeah.
a look, and
Which
be
obviously
like,
is not the most...
no, that's not how you want
It's
to be
not
diagnosed.
suitable for everyone, is it?
No,
Like,
definitely not.
Especially if you're in your 20s, you might not want a hysterectomy because you might want to have children. Even if
People
you don't
might
want to
just-
have children,
yeah.
you might not want to have
Might
a
just
huge
wanna have your
surgery.
womb.
And you might not
I
be
mean-
suitable to have a hysterectomy. There's loads
Yeah.
of people that aren't suitable because
Yeah.
they've had lots of surgeries or they're
Yeah.
carrying a bit of extra weight. There's lots of different things why a hysterectomy to diagnose something is absolutely ridiculous
Yeah.
unless
Yeah.
you think it's a
It's a bit
cancer.
old school. Yeah. Yeah.
And we know that this isn't a cancer, so we wouldn't be worried from that point of view. So we would look to be doing either a transvaginal ultrasound or an MRI. Transvaginal ultrasounds have really, really come a long way. We didn't used to be able to see a lot on ultrasounds. Now we can pick up lots of different things, and you can have a look at all of the different things that Alison mentioned before. So you're looking at that junction between the endometrium, the lining of your womb, and your womb. It should be really clear. If it's not clear and it's kind of blurred, indiscriminate, you can't decide how thick the endometrium is because you're not really sure where it ends,
Yeah.
then that could be a sign of adenomyosis.
Okay.
You can also have a disproportionate thickness in the front compared to the back. So like it's
asymmetrical, like your womb usually would be like the front wall and the back wall would be the same kind of like
Oh, okay.
thickness.
So like they'd grow the same amount.
But if one's a lot bigger than the other, that might be because it's inflamed, because there's adenomyosis
okay,
there.
okay.
So that can
Got
be
you.
one
When you
sign
said
as well.
transvaginal ultrasound, is this where the probe goes inside your vagina?
yes.
And then you can look from there?
Yes.
Okay. Can you see it on stomach
So you
ultrasounds?
can see your womb on a abdominal, so an
tummy ultrasound.
tummy ultrasound on a transabdominal tummy ultrasound. But you can see things so much closer and so much clearer with a transvaginal ultrasound.
Yeah. There's less between the ultrasound probe and the womb when it's a vaginal scan.
Yeah.
So when it's an abdominal scan, you've got your tummy wall, you might have some fat there, you've got your bowel, you've got other stuff, so it gets in the way of seeing the womb.
Yeah.
The only way
How big's
really
the
of
probe?
seeing the womb when it's on your tummy is if you've got a window. So you need to, if people are being told to fill their bladder before they go, so you've been told to drink lots.
So the bladder
Why
then
is
is
it called a
like
window?
it's
where are we?
it's like an
open the
ultrasound
curtains?
term, because your bladder on an ultrasound, if it's full, is black, and the ultrasound probe will show you through the
through it?
bladder.
Well, and also like it pushes everything up as well.
Yeah.
If you've got full bladder.
So it makes it a better image for the sonographer.
She's a window.
A window.
A little window
to the
in.
womb.
So it does make things much
like that.
easier. So people will come, you'll put the probe on and you're like, you've got nothing in your bladder.
You need to go and have
Yeah.
a big drink.
Yeah.
Or I can do a transvaginal scan knowing that I'll be able to see just so much better.
Yeah.
But then, so you asked how big the probe is. So the probe is, for a vaginal scan, is quite thin, probably like 3 centimetres sort of thickness, maybe a bit more sometimes, maybe a bit less. It goes in the vagina only, about the length of the vagina. So the probe itself is long. Might look a bit scary because where is that going? What is that for? But it only goes just as far as it needs to get to the neck of the womb and then see your womb. But the ultrasound, so there's one big problem with ultrasound to diagnose adenomyosis is that we still don't have like a set criteria to say it is that. So there's lots of different things you can see on an ultrasound scan that might be adenomyosis, but there's sonographers scanning women all over the world, and a lot of them are using different criteria to diagnose it. So it's not very consistent.
No.
So we're still working on, and there's like lots of research going into having like a set tick list of, okay, so on this scan, if you've got 5 of these 7 things, you can say it's adenomyosis.
Oh, okay.
But that doesn't quite
There's
exist
loads of
yet.
things.
Yeah.
So we said about this fat, thin areas of the womb, this indiscriminate border. You can get cysts within the muscle, which we think are adenomyotic cysts.
Okay.
So you can see those sometimes. And then there's this Venetian blind effect.
Like a fan effect from the ultrasound being like blocked by the adenomyosis lesions in the muscle
So
layers.
you get what looks like a...
It sounds fancy, but it
Yeah.
sounds weird.
Yeah.
But then like a lot of it can be really difficult with ultrasound, because if you have a fibroid, that can look like adenomyosis.
Ah, okay.
And in different times of your cycle, your womb might look different. So then it's good and it's getting better.
Yeah.
But if you've had an ultrasound suggesting adenomyosis, it doesn't definitely mean you do. It still needs to be kind of like, you need to see a doctor and think about your symptoms and maybe think about doing some other tests to see.
Okay.
I think there's just lots of different, as you've said, criteria, whereby when you've got an ovarian cyst, for example, we've got different criteria that we would do. Right, X, Y, and Z means this has got whatever chance of being a cancer or whatever chance of being a dermoid or whatever. We've got all this because we've got all the evidence. As we said, adenomyosis is a way newer kind of diagnosis that we're giving to people. So the criteria is just not in place.
Okay.
But we'll
So
get
we
there.
need-
Give
yeah,
it
we'll
50
get-
years or so. And we know exactly how to diagnose it from an ultrasound scan.
We need to be able to do more research.
Yeah.
Definitely. Yeah.
So we've said before that, like, with some of the different conditions we've talked about, that a diagnosis is great, but sometimes you don't need it to be treated. So, like, you've had an image and you think you might have adenomyosis. What can we do for them? What are you offering these people?
So it's the same as with endometriosis,
Okay.
really. So it's trying to treat the symptoms and hopefully get on top of the symptoms with medication before thinking about needing to do something more invasive like surgery.
Yeah.
Just to mention as well, we talked about ultrasound scan. You did mention that you can have a diagnosis on an MRI scan, and again, that's also looking for those same kind of like signs. And MRI is a bit better than ultrasound at diagnosing it. But yeah, it's kind of difficult, I think, for the person. If you're coming with heavy, painful periods, then the first thing you'll be offered by your GP or the gynecologist that you see will be pain relief, so tablets to try and control the pain, something to help reduce the bleeding. So that can be hormones, it can be not hormonal. It could be something called tranexamic acid, which is a tablet that you take kind of just during your period, which helps to make it a bit lighter. And there's a whole heap of hormonal treatments that can help with adenomyosis. So it could be things like the pill, it could be the coil, it could be an implant, it could be the GnRH, the injection that kind of puts you into a temporary menopausal state to try and switch off the hormones that are causing your symptoms. Lots of things that you can try, and some might work for you and some might not, but you might need to go back and try a few different things.
Yeah, it's difficult because I think people want a cure, and there's definitely no cure, and a lot of people don't want to be on hormones, and hormones can work very well, and a lot of people want to be on a hormone that they like, and Naga's spoken quite openly about the fact that she was on the depot injection. So we've talked about the depot before. It's a great contraceptive, and it usually means that you don't have any periods at all. So if you've got heavy painful periods and you're on a depot with no periods, then you're kind of living your best life. But actually depot is not suitable for the whole of your life because, well, of bone mineral density loss. So you have to think about risk, pros and cons, weighing things up, and you have to do this about a lot of things.
And can this be like a chat with your doctor about the options? And obviously it's not one size fits all.
No, exactly.
Have a look at what's best
Some
for
people
you.
would have, for example, a Mirena coil fitted, and they will feel much better because instead of having heavy painful periods, they're having much lighter periods, or again, no periods whatsoever. Some people are great on the combined pill, the progesterone only pill. There's lots of different options. But as you've probably heard me go through all those options, they're pretty much also contraceptive.
Yeah, so it's not, they're good for managing symptoms. They don't treat the adenomyosis lesions, they don't get rid of them. They're good for treating the symptoms that they cause. But if you want to get pregnant, you can't use hormonal contraception, so that can be a difficult time.
And is surgeries, so like hysterectomy, is that suitable for some people as a treatment?
Yeah, absolutely. And it can be a really good treatment because if we can say that your pain and bleeding is most likely caused by adenomyosis, then removing your womb should improve your symptoms.
If you just have adenomyosis.
Yeah, there's a big crossover with endometriosis. Yeah, so quite a lot of women with adenomyosis will also have endometriosis. And similarly, if you have endometriosis, you're more likely to have adenomyosis.
And if you've got endometriosis, that's
then a hysterectomy is not a
outside of
cure.
the womb,
Yeah.
Yeah, so that's the endometrium growing not in the muscle layer of the womb, but kind of anywhere else, most commonly in the pelvis or on your ovaries. So if you remove your womb, but you still have your ovaries and you have endometriosis, you're probably still going to have pain. You can have, we've done a whole episode on endometriosis, which you should definitely listen to go more into the different ways to treat that. But I think it kind of highlights that like people who have chronic pelvic pain, one cause is adenomyosis, but they often have other causes as well. And so just doing a hysterectomy might completely improve their pain, but they might still have some afterwards if they've also got endometriosis or other symptoms.
I think it's definitely not a one size fits all, and a hysterectomy isn't like an easy option at the end. And that's why people a lot of the times kind of complain that they've got to maybe jump through hoops to try and get to where they think they would like to be. And it's really difficult because a lot of times we want to make sure that we think that's the right thing for them. And hysterectomy is not the right thing for everybody. And again, it depends what stage of your life you're in. It depends if you want a major operation, it depends if you're suitable for a major operation, and it depends if you just have adenomyosis, because as we've said, if you've got endometriosis as well, it's really not going to help.
And there are some places in the world, some places in the UK, where they do different types of surgery for adenomyosis. So there's uterus sparing surgery. So essentially, if you don't want to have a full hysterectomy, maybe because you want to get pregnant in the future or for another reason, what you can do surgically is kind of open up the womb, remove the muscle that's affected, close the womb back up. There's various different ways of doing it.
That sounds complicated.
Invasive, complicated. It's not a lot of the surgeries that are happening are kind of happening, they're looking at whether or not it does help, reporting the outcomes to see if it's a good thing to do or not. But like China do a lot of adenomyomectomies. There are some places in the UK that do them.
In Europe they do.
Lots, in Europe. But the thing with that is that hopefully it will improve your pain. If you're doing it because you want to try and get pregnant and you do get pregnant afterwards, it's then what we would call a high-risk pregnancy. Because you've had surgery on your womb, there's a high chance that could cause problems in the pregnancy. The scar on your womb might open, you might go into preterm labour, you're probably not going to have a vaginal delivery, you're probably going to be recommended to have a C-section. So that might be the right choice for some people, but again, it's an option that exists.
It's a big step to take when we haven't got literature results,
Got all the
everything
info.
saying if you have this done, you
Yeah.
will then be able to get pregnant and you will be able to carry a pregnancy,
And you'll
or
have no pain,
you will have no pain, or
Yeah.
like, I think if you were going to have it done and we knew the outcomes, I would be a lot more kind of happy about that.
Yeah.
I think at the moment it's still very much in the realms of we think this might help, but we're not sure.
Yeah.
And does adenomyosis itself impact fertility or ability to get pregnant?
It can do.
We see more people with adenomyosis in a fertility setting, just like we see more people with endometriosis in a fertility setting. So we think that because of all the inflammation that's there, that might affect implantation. So the ability for that blastocyst, when we put it back into the womb, to be able to implant, form a baby, form a placenta.
And even if you're not in a fertility clinic, the thinking is, so most people who have adenomyosis don't have infertility.
Yeah.
Okay.
But there's a percentage that do. And the idea is, you know how we talked before about how the myometrium is all inflamed, and that means that the endometrium is also then affected. So you want your sperm and your egg to meet and have a nice, calm, chilled
Cozy
environment
place.
to go and get into the endometrium. If that's all inflamed, then it can prevent the egg and the sperm meeting and implanting.
Okay.
Now the other thing, and there has been some research done with this, which is really quite interesting, and you would like it because they've got some great videos from vaginal scans, is looking at contractions.
Okay.
Yeah.
So womb contractions, and what they've seen is that people with adenomyosis, their contractions aren't as uniform, they're not in the right direction. There's a lot of things behind it that we need contractions to be able to get that implantation to happen, and for the sperm to go the right way, for the eggs to come back the right way, and all this kind of stuff. So if your contractions aren't doing what they should be doing, then that could also be an issue. So that's one of the other things that we think causes problems with fertility.
But again, a lot of this is kind of, it's not
In the research
proven.
setting.
It's research. So we think that women with adenomyosis have lower fertility, but then you get loads of women who have full children, no problem, all vaginal deliveries.
Yeah.
So it's not that if you have been told you've got adenomyosis that you are infertile. Same with
this doesn't
endometriosis.
apply,
There is an association, but it doesn't mean that you definitely will not be able to have children.
No,
Because that's a
totally.
big panic if you've been told,
Yeah.
oh, you've got adenomyosis, and then you look online and it says you're infertile, and you're like, oh,
Yeah.
God, I'm going to have a hysterectomy age 25.
Yeah.
Not necessarily, yeah.
So a lot of chat about endometriosis, adenomyosis, and I've seen before them being called adenomyosis being endometriosis's evil twin sister.
Are they twins?
Are they
They're definitely
related
not
at
twins.
all?
They're probably
Are they related?
I think it's fair to describe them as like sister conditions because they often exist together. And also they are both similar in that it's endometrium in the wrong place. But obviously it's adenomyosis is in the muscle layer, endometriosis is outside the womb.
Okay.
So your
Cousins, not
adenomyosis,
twins.
Yeah.
it's not going to spread.
So no, not in terms of once it's in the muscle layer of your womb, those like lesions can grow and cause problems.
Get bigger in that muscle.
But it's not been shown that adenomyosis can spread through your womb and become endometriosis.
Okay.
It could do. We don't know for
Potentially,
definite. Because we do know that women with, with endometriosis, there's different types. There's sort of like 3 main types. The type that affects your ovaries, the type's like a superficial scattering on your pelvis.
Yeah.
And then you've got the deep type that can invade like your bowel or your bladder. There's some research, again, research not proven, that endometriosis, when it can invade into your bowel, could also invade into your womb. And maybe there's a subset of women who have deep infiltrating endometriosis that then get adenomyosis. But that is a theory. We don't know for definite. And also I think it's important that we want to just basically make your life better. If you're having symptoms, we want to know what we think is causing it. We want to give you treatment to try and make those symptoms better. It's really interesting from a research point of view to be like, oh, how does this happen? Like, but what we want to treat is the person in front of us and make their
Make
life
them feel
better.
better.
Yeah.
And adenomyosis, so by definition, can't be anywhere else because it's in the line. It's in the
That's what
muscle
it is,
there.
in the lining of
That's
the-
what
that's
it is.
it.
Endometriosis is kind of everywhere and can be everywhere and has been found everywhere.
Okay.
But adenomyosis, by definition, is endometrium in the muscle layer.
So we've said different types of endometriosis. Are there different types of adeno?
Yeah, so there's again research,
I feel
not
like this
proven.
is the theme.
So because we're getting better at looking at adenomyosis on imaging like ultrasound and MRI, people see different patterns in how these lesions are like formed in the myometrium. So in some women they have like a big focal area of adenomyosis,
Okay.
kind of like a big a fibroid, basically, but instead of it being smooth muscle, it's endometrium. So it might just be contained in one area.
Okay.
Whereas other women will have what they describe as diffuse, where it's kind of all throughout the myometrium. So when you see something like that, you think, okay, well, are these different types of the same disease? We don't know yet. There's also the kind of theories that deep infiltrating endometriosis might invade from the outside of the uterus to the inside. So when they see adenomyosis in like the outside of the myometrium, they call it outer adenomyosis, and maybe that's related to endo. Again, all just
this is the theme.
Theoretical. Yeah.
The theme is theories.
Yeah.
Obviously, when we spoke about our endometriosis episode, endometriosis can have stages. Does adenomyosis have stages?
No, it doesn't have like defined stages. It's when the endometrium is in the muscle layer. We may see different patterns. We don't know what those different patterns mean yet in terms of how your symptoms will be or if you'll respond differently to different treatments. Yeah. Essentially, if you have it, you have it, and there are theories of different types, but nothing proven yet that would really affect how you would be treated.
Yeah.
Okay.
Yeah.
So, like, future direction, ideal world, ideal plans. What are we going to do at Adno?
I think the main thing is that we need, as with endometriosis, more non-hormonal treatments.
Yeah.
And less invasive treatments.
Yeah.
So if you could like wave a magic wand, then it would be
targeting the lesions.
Yeah. Something that can.
Or even if I had to take a tablet, but it would target the lesions, I feel like I would do it.
That would be ideal, wouldn't it? If you can say that first of all, I think we need a better way of diagnosing it and being sure you've got it from an ultrasound.
Which I think that will come very quickly.
MRI.
I think people are on that.
It's like it's on the horizon now.
Yeah, I think there will be a consensus, just as there was for endometriosis, PCOS, ovarian cysts.
Yeah, they come through.
This will definitely be a very soon thing, I think.
And then once you can be sure that you've got a diagnosis, having better ways to treat it that are not just the typical what we have now, pain relief, hormones or hysterectomy. If we could have something that targets the lesions, that isn't hormonal, that has no side effects, that you can take and get pregnant, I mean, that would be amazing.
Sounds like a dream.
Yeah. So that's what you're going to do.
Yeah. We'll get that one
Yeah.
Yeah, that would be good.
Is there anything else we need to say before we move on to all the myths and questions?
No, I don't think
so.
I think that adenomyosis is genuinely, as we've said, kind of not a new disease, but it's a new thing that we talk about.
Yeah.
And I think there's so much now that we'll go into kind of characterising it, deciding where it's coming from, where it's going to, and how we're going to treat it. I think watch this space. I think this will be an explosion.
I think it's great that people are speaking about it a lot more as well.
It's kind of what happened for endometriosis 20 years ago, isn't it? Like people suddenly started talking about it, and then eventually the research follows and the money follows, and you get better ways to diagnose and treat it. And we're still improving endometriosis, but we're behind with its evil twin sister. But we'll get there.
So myths, So a first myth that we've got is that adenomyosis can spread through your body.
As we said, no. So adenomyosis by definition is the lining of your womb in the muscle of your womb, so not anywhere else in your body. Endometriosis, completely different. That's the lining of your womb found in lots of different places of your body, but adenomyosis, muscle of your womb.
And they often exist together. And then also I would probably just add that the symptoms of adenomyosis might appear in different parts of your body. So you might have just adenomyosis, no endometriosis, but you might feel bloated, tired, and that might make you think that maybe it is spreading, but it, as Nick said, by definition it is just contained in the muscle layer of the womb.
But the pain can
could be in other places.
So we've kind of we've kind of said that we used to think it only affected sort of older women and those who had kids, but is there any truth in the idea that having a C-section, because obviously that's quite invasive, and to get the baby out, is that gonna increase the chance of adeno? That
would class as like injury at that sort of endomyometrial border, so
still
technically
theorized?
I mean that isn't proven yet. We know that like in women who've had surgery on the uterus, they're more likely to get adenomyosis or have it, but it's not a definite, if you have a C-section you will get adenomyosis. That's not true at all. Good. Another,
it can be diagnosed by routine pelvic exam.
So you can diagnose quite a lot through a routine pelvic exam, and that's why we still insist on people coming to clinic and having a proper history taken and having an examination, because we can feel kind of size, shapes of wombs, whether we can feel cysts, that kind of stuff, but you wouldn't be able to diagnose adenomyosis without further imaging. And as we said, even with further imaging, it's not kind of a yes and no situation. It's an imaging plus symptoms plus everything else that's going on. It's really not that straightforward.
Could it ever be seen on a hysteroscopy?
No.
Well, again, research. So typically no, because if you think your hysteroscopy is looking inside the endometrial cavity, so you're just seeing that superficial lining of the womb from the inside of the womb. You can't see the myometrium.
No, but sometimes people do go into adenomyotic cysts if they're kind of doing scanning at the same time, and they can guide themselves. So you know, we were talking about an adenomyectomy where they are removing the adenomyosis from the muscle. Instead of going from above and opening the wall, then they could go from down below and do it hysteroscopically, but it's going to have to be quite sizable for us to be able to do that, because if you've got an ultrasound and a hysteroscopy from down below and trying for them to both join in the middle is not for the faint-hearted.
Listen to our hysteroscopy episode if you haven't, but basically that's a camera that goes into the womb
and has a look around.
and has
Literally
a look
looks at
around.
the
Just a random thought.
No, it's a good
Just
thought.
thought I'd check.
And it is like that it's not a standard way of diagnosing it, but you might end up having this procedure and they might do an ultrasound scan at the same time and if they have the skills. So it could be.
There could be a way to treat it that way, but it's not straightforward.
Not routine.
No.
And then I think sort of our last myth, which is actually quite a sad one, but we see quite a lot with like the women's health side of things, is, I think this was probably TikTok comments where we found this, but like, it's your fault, you've not managed your stress, your well-being, like, you know, you've brought this on yourself.
No, it's not that at all. And that's just such a really sad common theme with any gynae or any women's issue, that like you've caused it yourself. It's not true at all. So you being stressed or, I don't know, eating cold food every day. There was a weird myth about like hot and cold food causing gynae problems.
Or
none of that will cause
having a
adenomyosis.
termination, or
having that C-section,
a miscarriage, or having a C-section.
It's reminded me of the fibroid myth about the negative
Toxic
masculine
waste.
energy causing the fibroids.
That doesn't cause adenomyosis. No, you've not caused it. It's happened without you being
sort of spontaneously
involved.
Yeah,
It's happened to you, not by you.
That's reassuring, I feel.
And a few questions as well. Someone's asked, will a hysterectomy cure my adenomyosis?
Yeah, I think we kind of discussed this. So if you have adenomyosis and that is all you have, and you have heavy painful periods, and we think that they are caused by adenomyosis, then having a hysterectomy will cure your heavy painful periods because you will not have periods anymore, and it will cure your adenomyosis because that will be gone. But if you have anything else going on, so if you have nerve pain, endometriosis, anything else, then it won't help any of those things. So a hysterectomy would cure adenomyosis, but it might not be the cure for
your
symptoms.
And also a hysterectomy on its own can cause long-term
Lots of
pain.
things,
So it might not be the be-all and end-all.
And when you're signing up for a hysterectomy, when you're signing that consent form, there is so many complications on the consent form. It's a major abdominal surgery, whether you have it laparoscopically, so through keyhole surgery, or whether you have it open. It's a major abdominal surgery.
A lot of like stuff to be losing.
Oh yeah, definitely. And you're not going to be going to work the next day. You're not going to. There's a lot of impact regarding having a hysterectomy, so it's not to be taken lightly, and it also isn't appropriate for a lot of people that have had previous surgeries, that have got a frozen pelvis because they've got endometriosis as well, that are carrying a bit of extra weight, that have other comorbidities, so other medical conditions that mean it's not appropriate to go to sleep. There's a lot of people that a hysterectomy
isn't suitable
for.
And it shouldn't be a distraction. Like, you know, it does technically remove the adenomyosis, but that doesn't mean we shouldn't look for other treatments. Because it's not the best be all and end all, because as everything
Not
you've just outlined, it might be great for some people, but it's not suitable for everyone, so we still need other treatments available.
She'll still be working on it. The next question, I think we've touched on slightly, you know, there's differences between adenomyosis and endometriosis. They're linked, they're maybe not twin sisters, but is there a common cause because we've said that people, if they have one, might have the other. And when we talked about endometriosis, we talked about sort of like sometimes there's like a family history thing.
There's no known there's no known gene that you can inherit that causes endometriosis and or adenomyosis.
Okay.
But it does appear that in endometriosis, it kind of is more common if you've got a female relative with it, like your mum or your sister, you're more likely to have it.
Yeah.
You're not definitely going to get it, but there clearly is some sort of genetic link. We just don't know exactly what it is. And the same can be said for adenomyosis on a smaller scale because we don't have as much research to back that up.
Okay, so if someone's got adenomyosis, has a daughter, it's not for sure that
it's
that
not
daughter's
for sure
gonna have
definite that they're going to get it at all. No.
And if I have an MRI and it's not visible, does it mean it's definitely not adeno?
No, nothing's definite. You probably don't. But MRI, it's a good way of diagnosing it, but it's not perfect. So if your MRI scan is normal, you probably don't. But if you're still having symptoms of heavy, painful periods and you've had a normal MRI scan, that doesn't mean that the medical world will shut their door to you. You can still access help and you can still access treatment.
And also, MRI is not first line for anything. So if you came in and you were examined, or ultrasound is way more first line than MRI. We don't often do MRIs.
Another question we've got is, was I born with my adenomyosis or did it develop over time?
Really good question.
Yeah. Do we know?
Well, so there are some, like, you know, in the literature, case reports of like babies with adenomyosis.
Oh, wow.
And there's a certain type that seems to affect teenagers called juvenile cystic adenomyosis, where on an ultrasound scan you can clearly see these little cystic things in the myometrium that aren't connected to the endometrium. And this kind of ties back to like different theories of what causes adenomyosis. One of them is that maybe there's stem cells in the myometrium. So stem cells are cells that can become any cell type. And maybe there's some in the muscle layer that just decide to become endometrium.
Oh, they go rogue.
Yeah, they go rogue.
I remember learning about stem cells at school.
Yeah. So this again is a theory. It's not proven, but it would explain maybe why in some people you get it really, really early before you've had any of the risk factors associated with it. So yes, potentially you could have it as an early age, not necessarily born with it, but most women, it does seem that it happens later in life. It's not there at the beginning, and it seems to sort of form over time.
I think we've covered all our questions.
Great.
Yeah.
Well, thank you. I think that's everything we wanted to cover for today.
So
The last minute.
maybe not I don't know myosis anymore. Maybe we do know myosis.
I know myosis.
But we know what we don't know and what we need to know.
Yeah,
we do.
do.
It's important.
I kind of know myosis.
So just a quick disclaimer. So everything that we've discussed are our own opinions. They're not affiliated with where we work, and you shouldn't take anything as personal medical advice.
Yeah, so if you found this episode interesting, comforting, if you think you know myosis, please leave us a review and subscribe wherever you get your podcasts.
And this might be a really little thing, but if you give us like a 5-star review, this will push the content out further, and we really want to break barriers, bust myths, and give as many people as possible access to this information.
Yeah, so we want to reach as many people as possible with this podcast and this episode. And if you want to be part of that ripple effect, then please hit that like button.
So make sure that you are involved in our socials, follow us, engage with our content at Between Two Ovaries.